So let us come to the discussion of antiretroviral drugs, and we'll start with zerovudine. Zerovudine is basically belonging to nucleoside reverse transcriptase inhibitor. It is given orally and it gets incorporated into DNA of HIV and terminates its chain synthesis. And the viral DNA polymerase is about 100 times more susceptible to inhibition than of the mammalian cells. It is well absorbed orally and can also be given intravenously. Which is noticeable here, the 200 milligram dose can be given, or it can be substituted with 300 milligram dose. Modern clinical studies show that even 500 milligram per day of dosing is not that much toxic to the patient. One must be very, very careful about the anemia, granulocytopenia may caused by this zerovudine like drug, and this kind of thing should be treated with erythropoietin. These kind of NRTIs may lead to HIV lipodystrophy syndrome, which may be a kind of fatal metabolic syndrome. These may also lead to lactic acidosis and severe hepatomegaly due to mitochondrial damage. Resistance is pretty common with decreased effectiveness with all the groups from these nucleoside reverse transcriptase inhibitors. One of the most noticeable thing which can be observed here is that this drug is given in a pregnant lady with CD4 count greater than 200 per microliter, and it's beginning at weeks of 14 to 34 of gestation, plus the intravenous drug is given during labor, and the delivery plus this oral zerovudine to infant should be continued for 6 weeks, and it will only decrease the transmission of HIV by 67.5%. So the goal is to reduce the transmission rate. Next important drug from the same group which we should give much importance is lamivudine. It is best tolerated, one of the best tolerated NRTIs. This drug is given as a regimen of HIV infection even in the NACO regimen, and as well as it is used in our state in the country. So people are giving a combination of tenofovir, lamivudine, and the drugs like efavirenz. So lamivudine is one of the common drug which is used as a first line drug in case of HIV infection. It's probably, as I said, it's one of the best tolerated drug, but it may cause fatigue, GI disturbances, a little bit of flare of hepatitis, and lamivudine resistance may emerge rapidly due to M184V mutation, following which the cross resistance to the other drugs like abacavir, emtricitabine, galcitabine may also occur. This drug is not only effective against HIV infection, but it can also be used in hepatitis B virus infection. Its bioavailability of around 80% taken orally, and it is not dependent on administration is not dependent on food. Its elimination half-life is around 2.5 hours, and the intracellular half-life of the active triphosphate metabolite is around 11 to 16 hours. Much of the drug is eliminated unchanged in urine, but the dose requirement is required in case of renal insufficiency. Let us come to the third drug, which is not belonging to nucleoside reverse transcriptase inhibitor, but it is belonging to nucleotide reverse transcriptase inhibitor, and it is available in two forms. One is tenofovir disoproxil and the other one is tenofovir alafenamide. You have seen the name of tenofovir in multiple occasions, pre-exposure, post-exposure prophylaxis, almost everywhere. Also as a first line drug in case of HIV infection in combination with lamivudine and efavirenz used in our institutions to treat HIV infection. So, tenofovir disoproxil is given in a dose of 300 milligram, and this is basically the one which is given in combination with the antiretroviral other agents when treatment is indicated. It will reduce this HIV-1 RNA level to almost 0.6 log. It may cause renal problems or osteomalacia, may flare up of hepatitis in hepatitis B virus co-infected patients who will discontinue this drug. The other form, which is basically the tenofovir alfenamide form, given in combination with emtricitabine and other antiretroviral drugs for treatment of HIV-1 infection. It is given 25 milligram 4 times daily dose, and most of the patients treated in combination with emtricitabine and integrase inhibitor like elvitegravir, and elvitegravir is combined with cobicistat. Cobicistat is not a classical antiretroviral drug. It's a pharmacokinetic enhancer, and it will increase the concentration of elvitegravir when given in combination, because this cobicistat will inhibit cytochrome P450 enzyme system, mostly CYP3A4 and CYP2D6, and it also inhibits P-glycoprotein. Therefore, the concentration of elvitegravir is basically going to be increased in such cases, and it is metabolized by the same enzyme system CYP3A4. So, co-administration with cobicistat increases its concentration and favoring once daily administration, which will also increase the patient compliance. And nausea and renal toxicity is lesser in comparison to the other form, disoproxil fumarate. So, these are the two forms of tenofovir which are available in the market. Before coming to non-nucleoside reverse transcriptase inhibitor, let me allow to discuss a little bit about emtricitabine, which is basically belonging to the same group as nucleoside reverse transcriptase inhibitor. It's a fluorinated derivative of lamivudine, almost completely absorbed, and it has intracellular T-half of 39 hours. And you have seen this emtricitabine is always given in combination with tenofovir, both in pre-exposure and post-exposure prophylaxis. And in the developed countries, especially as per Harrison in USA, the recommendation is such that they are giving it in both in all kinds of HIV infection as the first line drug. But here mostly due to the cost and some other reasons, it is the lamivudine is still getting preference over emtricitabine. In non-nucleoside reverse transcriptase inhibitors, what we are observing here are some common drugs like nevirapine, efavirenz, and eltravirine. So, these drugs are like NRTI, their action is like NRTI. So, let us come to their common characteristic. They are most selective for HIV-1 reverse transcriptase, therefore are effective only against HIV-1. They do not inhibit human DNA polymerase. HIV isolates resistant to NRTIs remain selective to these drugs, and they are metabolized in the liver. They cause skin rash, hepatotoxicity, multiple drug interactions. Whereas nevirapine can also be given to prevent transmission from mother to fetus. Whereas efavirenz is a drug which is basically crosses the blood-brain barrier, which most other anti-HIV drugs fail to do, and development of resistance to this drug is claimed to be slower than comparison to the other older drugs. Once daily formulation is good enough, and adverse drug reactions like dizziness, insomnia, hallucination, abnormal dreams, and rarely pancreatitis may occur with this. This drug is teratogenic in animals, but review of the available data suggests that exposure to this does not result in increased birth defect. So it's a mixed inducer and inhibitor. It's a mixed inducer and inhibitor of CYP3A4 system. Nevirapine is more effective in comparison to efavirenz, and it penetrates the CNS pretty well. So this is about non-nucleoside reverse transcriptase inhibitors. So the third group, which is extremely important, is called the protease inhibitors, and these drugs are listed here. And the first drug which is being mentioned is Ritonavir, which is not giving in the full therapeutic dose because of its toxic effect. It is only giving at a smaller dose so that it can boost up the use of, or boost up the effectiveness of the other protease inhibitors like saquinavir, lopinavir and atazanavir. They have certain common characteristics. They are inhibiting aspartyl protease, which cleave viral proteins and effectively arrest replication. They will block the infectivity of the nascent variants. They prevent the subsequent waves of infections. They have no effect on cells already harboring this integrated proviral DNA. Orally, they are extremely well tolerated and metabolized by hepatic CYP3A4, except nalfenavir. And most of them, they inhibit CYP3A4 system. As I said before, the most potent one is Ritonavir. It is given at a very small dose with any other lopinavir like drug, any other protease inhibitors. And this Ritonavir will allow the reduction in the doses of the other drugs, so it will reduce its toxicity. This is a kind of boosted regimen termed in pharmacological perspective or viewpoint in case of HIV infection. Nausea and abdominal pain, hyperglycemia, fat distribution, lipid abnormalities are very common with Ritonavir. There is another group called entry inhibitors. Normally these drugs are given as add-on drug. It's basically a fusion inhibitor. Just by listening its way of action, you may think that is probably going to be very effective, but it's not like that. It should have been acting like a vaccine because it's blocking the first step of entry of HIV in variant inside the cell, but that thing is actually not happening. So in terms of efficacy and potency, it less effective in comparison to the previously used drugs or the classical drugs. The enfuvirtide is given, as I said, given in combination with as an add-on therapy with other drugs. It's a synthetic HIV derivative peptide and selectively inhibits membrane fusion of HIV with cells, and it prevents their entry into the cell. It is administered subcutaneously, so it's a subcutaneous preparation twice daily, and it is reserved for patients resistant to other drugs. Apart from local reactions, it may cause lymphadenopathy and peripheral neuropathy and suppression of interleukin 12, that is called IL-12. Whereas the second one, which is highlighted in almost yellowish orange color, that is the Maravirac, and Maravirac is chemokine receptor 5 antagonist and prevents entry of CCR5 tropic virus in the host cells. It is given in combination with other antiretroviral agents, so it also can be given as an add-on therapy. If you look at these two drugs, enfuvirtide at the top and this drug is Maravirac in the middle, both of them are probably used with the other drugs, and where Maravirac is showing some kind of effectiveness or better efficacy, and it's reducing this HIV RNA levels in comparison to the placebo group who are not getting the same drug. This is only seen in a randomized clinical trial, whereas the above one is also, enfuvirtide is also showing better effect in comparison to placebo. Enfuvirtide is given as I said in subcutaneous via subcutaneous route, and local injection reaction, hypersensitivity reaction, increased rate of bacterial pneumonia may occur with this. Hepatotoxicity and nasopharyngitis, fever, musculoskeletal symptoms, dizziness are common with Maravirac, which is basically a chemokine receptor 5, that is CCR5 antagonist, or in other terms it may call a co-receptor antagonist. So we'll shift to the last group of drug in the next slide. The last group of drug which we are going to discuss is the integrase strand transfer inhibitors, and few of the well-known drugs are raltegravir, elvitegravir, dolutegravir. So these three are very common, and beside that there is another drug which is bictegravir. So we're starting with the raltegravir. It blocks the enzyme HIV-1 integrase needed for viral DNA insertion into the host genome. It is used orally in combination to treat patients with multi-drug resistance HIV-1 strains. But in integrase dominated regime, these kind of drug may be used as a first line drug with tenofovir and emtricitabine. Whereas elvitegravir is basically a drug which is administered with a pharmacokinetic enhancer cobicistat, which is an inhibitor of CYP3A4, CYP2D6 and P-glycoprotein. And elvitegravir is metabolized by CYP3A4. Co-administration with cobicistat increases its concentration, favoring once daily administration. The combination is contraindicated with drugs which are metabolized by CYP3A4. Dolutegravir is basically another one which is belonging to the same group. So with this we are coming to the end of our presentation, and hopefully you can remember the basic groups, their common characteristics, and the common adverse drug reactions which are being seen in clinical practice. And besides all these drugs, few of the drugs are probably under the stage of development. One such drug is called Bevirimat, and this is a maturation inhibitor of HIV. And people are still trying out for HIV vaccination for a very long time. So with this, for a brighter horizon and seeing something positive and seeing something new in the treatment of HIV infection, I am concluding the session of antiretroviral drugs.